warm welcome to Soweto Healthcare Hub and specifically Apex Surgery Center. I'm glad that a number of you came in early enough to be able to take a walk around and to see and hopefully appreciate our world-class facility. Apex Surgery Center is a 3-theatre, 1 procedure room and 24-bed day hospital. And it is the only day hospital in Soweto. Dr. Damini will testify, Dr. Tshisikule will testify. And we're proud of that because it's long overdue that we have our own services being provided for our people where they live. This evening, we are going to have a talk as advertised on back pain and back pain management. And we are fortunate to have 2 speakers who are very learned. The first of our speakers will be Dr. Christopher Tshisikule. Dr. Chris, as I like to call him, began his medical journey in 2007 when he did, or rather when he qualified with the BSc in Biomedical Sciences. After having completed that, he went on to do an MBBCh. That gives it away, where he graduated.
Yes.
He's a Bitsy. They're the only ones that do it that way. The rest of us were MBChD. So after he completed his MBChD, or rather his MBBCh in 2011, and obviously we all know the trajectory we all follow, especially these days. Some of us are fortunate enough not to have had that. But the newer crop have to then do a housemanship, subsequently they have to do ComServe, and then potter around looking for jobs, struggle to get reg posts. We struggle for different reasons in our time. These days they struggle for different reasons to get reg posts. But he managed to get his reg posts in orthopaedics, once again sticking to the same institution. Not sure why, Chris. But in 2023, he got his fellowship in orthopaedics, and in 2024, as if that wasn't enough, he decided to super specialize, and he super specialized in spine, a very, very delicate part of the anatomy, and that's what makes him the most appropriate person to talk about back. You also got a number of certificates related to that. I suppose the most relevant one being his latest one, which was from the World Institute of Pain. And that is the main thing that we're addressing today. Chris, without further ado, the floor is yours.
Thank you, Don.
Sure.
Thank you, everyone. Good evening, ladies and gentlemen. I really appreciate you taking your time from your family or anything else that you could be doing to come here tonight and listen to our talk so that we can educate each other. So he says he doesn't know why I went to WITS and even my spinal fellowship at WITS. They say WITS gives you the urge. I needed to get hold of that edge so that today I can be here and share this wonderful topic with you. So by a show of hand, can I just see anyone here who doesn't have back pain or never had back pain? Never had back pain? Wow. We need to take your sample for genetic testing because you could be a key to future medicine. But basically, and we're going to come around this again towards the end, basically all of us at some point in our life, we struggle and suffer from back pain for different reasons. And today I'm here to educate you about which back pain to take serious in your practice and which back pain to treat in which way and which back pain to refer. All right, so let's start with it. I know that an attention span, especially for doctors, it doesn't last more than 15 minutes. So this table here basically summarizes my entire talk. I'm going to go through it in about 5 minutes or 10 minutes, and hopefully if you can grasp what I'm saying here, you would have grasped a lot of what I need to talk about today. There's still more very important slides, but this forms the foundation of what we need to talk about. So back pain generators. Where does back pain come from? It can either come from the back itself, or it can be a pain that is referred from elsewhere, right? And then the sources of back pain that originates from the back, it can either come from the muscle, then we call it musculogenic back pain, and this is what most of us experience usually due to work ergonomics, how you sit, how you bend, and everything that you're doing for ladies when you're cleaning at home, and men who clean at home, and so that causes muscle strain, and it gives you musculogenic back pain, which usually presents as lumbar spasms. And Mr. Mashilo will tell you more about what needs to be done for that, because usually it doesn't really have to come to us. And there's a say that back pain actually belongs to the GPs. But there's a point in time where you need to recognize which back pain needs to be escalated. Hence, we're having this talk here today. Then, the second part of back pain, it can come from the disc. So, intervertebral disc, and we call that discogenic back pain. That can present in two ways, as lumbar disc herniation or degenerative disc disease, degenerative disc herniation. Now, the difference between the two is that if I get disc herniation, it's going to be a lumbar disc herniation. Without saying anybody's age, but I'm just going to look in this center area here to say that if a disc herniation occur in this area here, it's going to be degenerative. And what that means is that, so when we speak about arthritis is a degenerative, osteoarthritis is a degenerative disease of a joint. What happens is that in layman terms, the fluid content in the body, it gets dried out as we age. Everybody goes through that. There's no escape. Even you, my young good sir, when you get older, you will experience that. So, with age, the fluid gets dried out, and then the bones get closer to each other. They start causing friction on each other. As a reaction of the bone grow osteophytes, and the rest, sclerosis, all those signs of osteoarthritis that we know very well. Now, when you are still young, the pressure inside the disc, which is the disc is made of nucleus pulposus in the middle and annulus on the outside. So the pressure inside there, it's so high that it is compared to a pressure inside a car tire. That's how much of a pressure is inside the disc. But it varies depending on position. Young people in their 20s, 30s, and 40s, sometimes when they get disc herniation, it usually happens when they are bending forward, lifting up something, then you feel something going on the back, and from there it's severe back pain. You will never miss this. When they come to your practice, they will tell you, I felt a pop on my back, and all of a sudden there's this severe back pain, maybe shooting to one of the legs or both legs, or I can't walk. If they say I can't control my urine, and number two, you send them right away to us, to the spine surgeons. So that's the degenerative disc, the lumbar disc herniation of young people. The degenerative disc, what happens is that as the fluid content dries out with age, it starts, the annular weakens, the annulus fibrosus weakens. And then that disc, little by little, it comes out of the intervertebral space and it encroaches the canal or the foramen of the spine. And that is when they start experiencing chronic back pain. Bit by bit, it's worsening. Now there's radiculopathy to the leg, or there's cramps and numbness. So that one, it occurs slowly, gradually over a period of time because it's degenerative. It's not coming out with a lot of pressure. All right, and I've highlighted this because discogenic, because that's what I'm going to focus mainly on. I won't be able to describe everything in details. If anyone has questions towards the end, we can go back and discuss the other concept. Now, the other part that where one can get back pain from is from the facet joints. Those are on the back of the spine. So arthritis, as we have said, it's a joint disease. The proper joint of the spine is not the intervertebral disc, it's the facet at the back where you've got two facets, a capsule and fluid inside. So if we were just to talk about, it might be on the next slide, if we were just to talk about the pathogenesis of back pain, chronic back pain, how it happens is that most of the times it starts with degenerative disc. When the disc is degenerated, okay, one step backward. 70 to 80% of body weight is transmitted through the vertebral body and the intervertebral disc in that anterior column of the spine, and about 20 to 30% it's on the back, meaning the lamina, the facets, and the rest. So when your disc is degenerated, there's too much pain when you load on it and you're standing or you're sitting. So you tend to want to put more weight on the back. The back is not, the posterior elements are not meant to carry weight. When you do that, you start straining the facets on the back. They become arthritic. When they are arthritic, now you've got arthritis on the back, you've got disc that is degenerated anteriorly, you get instability. Now the spine starts moving about. And that is when some of the patients, especially at L4, L5, because that's the biggest disc in the body, you start getting instability there. And the end stage is autofusion, wherein the bone will end up on top of bone, and bone on bone, it always fuses. All right. So facet arthrosis, it causes mechanical back pain when you're loading. It causes instability. Deformity, we're talking about scoliosis, kyphoscoliosis, that can result in back pain in a long run. Inflammatory. So we're going to come to history taking and so forth on the subsequent slide. If a patient has back pain, one of the questions that you need to ask them is the pain worse with activity or at rest? Or the other way to ask it is, do you get more night pain than during the day? Because that implies inflammatory type of pain. Inflammatory type of pain can come from infection, it can come from malignancies, it can come from inflammatory diseases like your rheumatoid arthritis and the likes. So that is the pain that you don't want to miss. If someone says my pain is, and it doesn't matter where in the body, whether it's the hands or the knees, when that pain is worse when they are at rest and they say I have to walk around to relieve it, it means it's inflammatory and you need to work out the patient for something like rheumatoid arthritis, infections, malignancies, and so forth. So that is another cause of pain. Fractures, we're talking about whether it's trauma. Fragility fracture, it's usually in old, especially postmenopausal females, but very old, who are osteoporotic. Without doing much, they just come complaining of pain, and you do x-rays, you find multiple vertebral compression fractures. That is because the bone has lost its quality and they get osteoporotic fractures. Pathological is those that they get vertebral planar or compression fracture of the vertebrae because they've got infection or malignancy. So any bone, any vertebral body compression in the spine, you need to take it serious. All right, then the referred pain, I'm not going to dwell much into this. It's either AAA is abdominal aortic aneurysm. So, sometimes you need to put your hand in there to feel, you will feel it palpating against your hand. If it's the pyelonephritis, very important. You guys, I'm sure you're expert of this. Renal angle tenderness, bending of micturition. It should be part of history to rule out the rest. Peptic ulcer disease, if it's perforated, it can radiate to the back. Pelvic inflammatory disease in females. Myocardial infarction, sometimes they can complain of pain to the back or to the shoulder, so you need to be aware of that. Pancreatitis as well, radiating to the back. Okay. Now, how this patient can present, you get a patient who has back pain without radiculopathy, and patients with back pain with radiculopathy. So, Pathophysiology is a little bit different. When you get a patient who's got back pain radiculopathy, and radiculopathy meaning pain radiating to the leg, and the leg pain is severe more than back pain, and they usually come and they are rubbing their thigh, they're like it's over here, doc, or their calf. That is usually a disc herniation pain, unless otherwise stated otherwise. So usually, like almost all the times, that is a disc herniation, and it could be degenerative if they are old. It could be herniation if they are young, and that history of picking up something heavy and a pop on the back. Then the other thing you need to look out for is their numbness, is their cramps, is their weakness. Neurogenic claudication is claudication. We are taught in medical school that when you're walking, you start feeling calf pain because of poor blood supply for patients with peripheral vascular disease. Neurogenic claudication, it means that when you're walking or when you're standing, you feel pain because of compression on the nerve. So it's pain that is coming from compression of the nerve. And what differentiates the two is that vascular claudication, if you're walking and you stop, it is going to stop because there's no demand of more blood supply to the muscles. Neurogenic claudication doesn't stop. If the patient is standing, as long as they're standing or walking, that pain is there. What relieves this pain? You ask them, when you bend forward, do you feel better? Yes. When you're at the shop, are you using a trolley to push? Because then they lean forward. When they lean forward, they are opening the space at the back. They are removing the compression from the nerves, and the pain gets better. All right. So basically, when these things are associated, it's just a red flag to say, take this pain a little bit more serious. Now, spinal red flags. Who should not have back pain? Kids under the age of 15 must not have back pain. And people above the age of 55 must not have back pain. Now, that's a controversy because everyone above 55 has back pain. Right. Yes. Yeah. So, the only reason that age above 55 is there is just so that you think about the other causes of back pain, mainly the inflammatory ones. That elderly people, when they have back pain, it's unlikely going to be rheumatoid if they have not been diagnosed. But you need to think of malignancy, you need to think of infection, and more so malignancy. So old people who have back pain, ask them, have you had cancer before? Because if yes, that back pain is metastasis until proven otherwise. And metastasis means that the patient is fighting against time. Right, so that's the reason why it's there. Now, patients with neurological fallout, especially as represented by bowel and bladder dysfunction, those you refer them right away. Patients with unintentional weight loss, so more than 10% loss of weight in the previous 6 months, that is unintentional. That implies malignancy or chronic infection like TB. Night pain, as I've said, that pain at rest is inflammatory, like malignancy, infection, your rheumatoid arthritis, and the rest. History of malignancy, I've touched on that. Fever or IV drugs, this is discitis until proven otherwise. And these patients, how they differ from everybody else is that they won't let you touch their back. When you say, can I palpate, and they jumping around, if there's history of infection or history of fever, chills, that is discitis until proven otherwise, and they need to be referred. All right, and patients who have got fractures. How do we manage them? First of all, prevention is the best cure. Can we prevent arthritis? No. Then it means that the next line is the GPs, the physios, then the spine surgeon. Then pain alleviation, physio, medication, injections. Return to play and return to work. I don't know if some of you see a lot of young young men or even elite sportsmen, because if they come to you with back pain, they want to know, when can I go to play? And those who are working, they want to know, when can I go back to work? So we'll touch on that in a bit. And then in terms of return to pre-injury state or to baseline of functionality before this back pain. And then we need to prevent recurrence. Did I say that first table was the most important? Now I need your another 10 minutes or so, because this is also quite as important. What do we do when we've got these patients with back pain? All right. Like I said, my main focus is lumbar disc herniation and degenerative disc disease. Non-surgical and surgical. So obviously, that's me. This is everybody else. Medical, NSAIDs, please try to refrain from using prednisone. I know the patients feel good. If you do give prednisone, make it a week or so to relieve, not more than that, to relieve that acute inflammation and the pain that they're feeling. Because in the long run, prednisone has got a lot of side effects that are detrimental to the patient. They're better off with that pain that they're feeling than chronic prednisone prescription. Muscle relaxants like your baclofen, even some NSAIDs, diclofenac, and them, they do work as muscle relaxants. Analgesics, in the beginning, we try not to give too much of high dose of analgesia, but if you must, you should, because once you put them on high dose, it's difficult to wean them off. Then there's psychological, because most of back pain, it has been proven that it is linked with job dissatisfaction. So that is one area that you need to explore to find out if this is not your area of expertise. Refer to the right people who can manage. They've got occupational therapists at work and social workers and psychologists who can help with this. And there's something called Waddell signs. If you look those up, it's pain that is supratentorial, and that needs a psychologist. You do a straight leg raise, and this person is in so much pain. You tell them a story while you're lifting the leg and you've distracted them, there's nothing. There's a couple of tests that you can do to check if that pain is really organic or non-organic. All right. Then epidural corticosteroid injections. This will give caudal transforaminal. I'll talk a bit about that very soon. Then when it comes to surgical, if it's just disc herniation of young age, usually microinvasive surgery to do discectomy through a portal endoscopic or through a tiny incisions, and that's about it. And then if it's degenerative, usually because there's already instability, if you just go and remove that disc, you're going to cause even more instability. So we usually have to fuse at the end of the day. So, here I'm just focusing on lumbar disc herniation. So plus minus fusion is because we don't like fusing young people. That's why it's plus minus here. On the next slide, it's mainly the same thing, but TLIF means we're fusing the transforaminal lumbar interbody fusion. So we decompress and fuse. Or you can just do a laminectomy if there's still stability. The one other thing that I've added is, that was not in the previous slide, is that when you do epidural corticosteroid injection, we can add facet blocks. So facet blocks is because the arthritis is on the facet. If you give steroids on the facet, you block the medial branch that supplies pain to the facet. So although the facets are arthritic, they are not going to feel pain from those facets for a period of roughly 6 months. Okay. Now, approach to this management is, first line, it's non-surgical. And corticosteroids, I should have put it lower down. So let's start analgesics. I've already mentioned not too strong, don't give too strong because it can mask pain. Be aware of addiction. For patients with severe pain, yes, you can give them more. And then psychology, I've touched on that. Physiotherapy is going to touch on that. The corticosteroids injections are as important as the Voltaren that you give on the bum or on the shoulder. Because what you need to do with that is, you want to alleviate pain. For those who are in too much pain, you want to alleviate pain so that when they go to physiotherapy, they are able to cooperate. Because some of them, they will go to physiotherapy and they've got an appointment to go back, and they don't go back because they feel that they were caused too much pain. And they will keep coming to you to say, just give me that injection. The Voltaren will last a day and it's out. The corticosteroids can last up to 6 months in the body. All right. So then I've just put these slides here, they're visible. All right, yes. So the top slides, this is some of the injections that I've done. So this is the caudal injection that goes at the sacrum. So you're going in, just as you do spinal anesthesia where you have to go through ligamentum flavum. So at the bottom there, there's an opening round about S3. There's a cone where when you palpate, you can feel there are ridges. And in between the ridges, when you put the injection, we always do it under CM guidance as shown here. The needle is inside. I push a bit of contrast to confirm that I'm in this space in there. And on this patient, you can see as the contrast went in, is going through the foramen. So that you are 100% sure that it's in and is going to do what it's supposed to do. This is most important for pain that is coming from L5S1 plus minus L4S5, and that is where sciatica mainly comes from. Here I was just showing how I do facet blocks. So you do a Scotty dog view, you get a pedicle, that's a facet joint, one this side, one that side. So on the top corner of the pedicle, that is where the medial branch runs, which is the nerve that supplies pain to the facet. All right, and then now the boring part, which I'm going to go through very quickly because everyone is going to fall asleep now. It's statistics. This, in 2019, they did a study of 342 professional basketball, American football, baseball, and hockey. And they found that in the general population, more than 90% of patients with lumbar disc herniation, they will recover within 6 weeks. So this is without any operation. You give them your first analgesics, and they should not be lazy. If they're too painful, you give them maximum 3 days. They need to start physio right away. If they are lazy, the spasms is just going to be a vicious cycle. And then in the elite athlete group, 80% of patients with lumbar disc herniation, they will recover either with surgical or non-surgical intervention. That's a good number. But if you're in that 18%, the consequences, if you're going to get Koda-Equina syndrome and so forth, hence you have to be cognizant of the symptoms that I was mentioning in the beginning to pick up those who are at risk of not healing from their degenerative disc disease. And then when they compared patients who had removal of discectomy, 75 to 100% returned to play. So we're talking disc herniation on the elite sports young men, right? So they were able to return to play between 3 months and 9 months. They were back to the work or the sports that they were doing. But the pre-injury performance was only between 64 to 104, meaning that majority of them didn't perform as good as they did. But if they're able to go back to play, then that is good enough. And then those who had microdiscectomy, 85% was able to go back to play. And this is in all sorts of different sports activity. The conservative management, 79% was able to go back to play. So you think about it, if I'm going to offer someone surgery, I always quote these numbers to say, by the way, if I don't do anything, 80% chances are that you are going to go back to whatever you were doing. But it will take a little bit longer. If I do something, 85%, you gain 15% extra from the surgical intervention of removing the disc. And remember, like I said, the spinal injections are part of conservative management to alleviate that early pain. If you feel your patient is in too much pain, you send them to us so that we can alleviate the pain with the spinal injections. All right. And those who had percutaneous discectomy was 70%. The linemen, these are the numbers. Surgical, 80% were able to go back, and about 13.5% needed further surgery out of that. And then the non-surgical group, only about 63% was able to go back to their sports activity. So there's a big of a, depending on which sports you're doing, you need to consider that to say, do they need surgery or do they not need surgery? The basketball players, post-operative, performance was decreased in the first season because they're still recovering, and it improved to baseline on the second or third season. This other study that was done in 2021, they were just doing a literature review of 20 studies that was looking at patients with disc herniation. And they found that 663 out of 799 patients, which is 83%, they were able to return to play in about 5 months. And then those who were not operated, 81% of them, they were able to return to play in about 4 months. So the reason for this is because the ones who are operated, they still need to recover from surgery as well. So they get a month delay to return to sports because of the surgery that needs to heal. Now, this might be my second last slide, so just stay awake for 2 more minutes. This study in 2013 showed that those who went non-operative care, 31 were not operated, 48 were operated with discectomy, and 8 had a single level fusion. The return to play for all players was about 85%, so there was no difference. And then a comparison of the post-treatment results for the non-surgical and surgical patients group basically revealed no significant difference, right? But notably, the lumbar fusion group did not show any decrease in games played per season or performance score after surgery. This is likely due to the fact that that 8, you see, is not a good sample to deduce anything from it. And now, the last study that I want to tell you about, it's, so they had 21 athletes, and this was just to compare the VAS score pain for the leg. To say in the beginning, they were at about 64, and then post-discectomy, the pain went down to 12. And then for lower back pain, from 62, it went down to 10. And then the ODI score, from 31, it went down to 14. And there were no complications in this study that was related to surgery. So 95% of these patients returned to sports at the same performance level as before the procedure by an average of 9 weeks. After, this is percutaneous, so it's minimal invasive. They don't need too much time to recover from surgery. In conclusion, conservative management is the mainstay of back pain treatment. Both surgical and non-surgical groups have got comparably high rate of return to sports of about 80 to 85% for lumbar disc herniation, and more than 90% of return to work for regular jobs. So you and I should be able to go back, whether we're treated operatively or non-operatively, more than 90% should be able to go back to their regular jobs. We do regular jobs. And then the patients with minimal invasive surgery, they were able to go back earlier in 9 weeks. And then recovery rate post-discectomy, as I've said before, 3 to 9 months. Conservative management must always be considered as first line. That's the point that I want to re-emphasize. And that, ladies and gentlemen, concludes my talk.